A 39-year-old man with a recent diagnosis of human immunodeficiency virus infection was transferred to this hospital from another hospital because of fever, sweats, and psychosis. The patient had been well until 4 months before admission when fever with temperatures up to 40.6 degrees Celsius, night sweats, and chills developed. During the next 3 months, anorexia, non-productive cough, and unintentional weight loss 7 to 14 kgs occurred, associated with early satiety, epigastric burning that improved with eating, and abdominal pain that was intermittent, mild, and crampy. 2 courses of antibiotics were reportedly administered without improvement. 6 days before admission, the patient was seen in the emergency department at the other hospital. The evaluation was reportedly negative. A skin test for the TB was administered and he was discharged. The next day, he saw his internist. CT of the abdomen after the administration of contrast material revealed a thick walled mass near the duodenum around 7 centimeter to 2.77 centimeter by 2.2 centimeter with air in its center. Scattered lymph nodes were near the porta hepatis, a thickened gallbladder wall, and mild splenomegaly, 13.5 centimeter, that the patient was admitted to the other hospital. On examination, the patient was alert, oriented, cooperative, and thin with shaking, chills. The temperature was 38.5 degrees Celsius. The blood pressure was 135/76, and heart rate was 106 beats per minute. The respiratory rate was 20 beats per minute, and the oxygen saturation was 93% while he was breathing ambient air. There was mild epigastric and right upper quadrant tenderness with no induration at the site of the skin test for tuberculosis. The hematocrit was reportedly 31.9%. The white cell count 4600. The blood level of the alkaline phosphatase was raised, that is to 233 units per liter, and the level of aspartate aminotransferase was normal, 47. The broad spectrum antibiotics and intravenous pantoprazole were administered. So during the next 2 days, the temperature rise to 39.4 degrees Celsius and the stools became black and tarry. The hematocrit was 28.3. MRI of the abdomen after the administration of contrast material revealed a thick walled lesion that was contiguous with the posterior medial wall of the duodenum, mild distension of the gallbladder, and the small amount of the fluid adjacent to the gallbladder wall. A unit of red cells was transfused, and on the fourth day, the esophagoduodenoscopy revealed a duodenal ulcer and a gastritis. Testing for antibody to HIV was positive. During that night, the patient became agitated, reporting a nightmare in which he was dying. On the fifth day, he appeared tense, speaking with his teeth and fist clenched, with his eyes staring ahead. Religious delusions developed. Psychiatric consultation was obtained, and olanzapine was added. The patient was transferred to this hospital. The patient had a herpes zoster of the thoracic dermatome 4 years before admission and again 3 months before admission. He had no known allergies. He had emigrated to the United States from the Caribbean country more than a decade earlier. Testing for HIV and syphilis had reportedly been negative 11 years before admission. He had a history of alcohol abuse and did not smoke or use intravenous drugs. He lived with his partner and her children. He had biological children who lived in his native country. A bird and a turtle were in the home. His parents and the siblings were healthy and with no family history of any psychiatric illness. On admission, the patient was awake but initially unresponsive. The temperature was 37.6 degrees Celsius and the blood pressure 148/80. Other vital signs and the remainder of the physical examination was normal. He became agitated and continued to have bizarre delusions. Olanzapine and haloperidol was administered. On psychiatric examination later that day, the agitation had resolved. He was not oriented to date and was found not to have a capacity to sign out against medical advice. 24-hour accompaniment was begun. Blood levels of platelets, bilirubin, amylase, lipase, calcium, phosphorus, magnesium, vitamin B12, folic acid, thyrotropin, ammonia were normal, and as were the results of the test of the renal function and urine analysis. Tests for the toxic drugs and hepatitis B and C were negative. Other test results as shown in the table 1. WBCs were 6700, hemoglobin 11, neutrophils were 86, lymphocytes were 9. T cell subsets, absolute lymphocyte count were 463. CD4 T cell count was low, that is 30. CD8 T cell count 322. APTT-PT was normal. INR was 1.3, sodium 136, potassium 3.2, total protein 7.7, albumin was 3.5, alkaline phosphatase was 266, immunoglobulin IgG was 1759. HIV antibodies by ELISA were positive, confirmed by the Western blot analysis. HIV nucleic acid were 8,93,000. On formal psychiatric examination on the second day, the patient had disorganized and guarded behavior, flat affect, thought blocking, and bizarre nihilistic delusions, including statement that he had died or was dead. Although the cognitive examination was limited in scope because of the patient's lack of cooperation, it revealed deficits in the attention, interrogate memory, and the performance of the visual spatial task. In the absence of fluctuations in the absence of any fluctuations in the level of consciousness. So on the third day, the patient appeared lucid and somber and had appropriate speech content. The maximum temperature was 40.3 degrees Celsius. There were white plaques on the tongue, scars from the zoster on the right thorax, and small rubbery lymph node adenopathy in the left axilla. Blood tests for the IgG antibodies to toxoplasma, cytomegalovirus were positive. Toxoplasma was positive, huh? And testing for the syphilis, CMV, antigen, strongyloids antibody, cryptococcal antigen, and urine histoplasma antigen were negative.